Yeah. At the outset, I would like to thank the organizer for inviting me. I will be in next 30 minutes. I'm talking about the imaging in ring enhancing lesions. I've taken the liberty of adding 1 or 2 adult patients just to complete the spectrum of imaging findings. Like ring enhancing lesion is an imaging morphology which we see on after introduction of contrast on CT scan and MRI. And we know that this is secondary to the breach in blood-brain barrier, which leads to leakage of contrast and accumulation of contrast in the extravascular spaces. We don't see the gadolinium itself, but we see the effect on the surrounding brain parenchyma. It causes shortening and we see the enhancement. What are the causes of this ring enhancing lesions? This ring enhancing lesion can be single or multiple. The most common cause is the infection, where neurocystic sarcosis, tuberculoma, and abscess are the common causes. Then we have the two-factor demyelination. Tumors are rare in the children. And similarly, in the adults, in the multiple lesions, the infection is the most common cause. How to approach these ring enhancing lesion on imaging? We have to look at 2 things. First is the clinical. What is the clinical presentation? Whether the patient is presenting acutely or chronic, whether symptoms are progressive, or whether the patient is immunocompromised. The causes are different whether when the patient is immunocompromised or immunocompetent. Then on imaging, we look for the size, core, the wall morphology, enhancement pattern, diffusion, perfusion. These are all the things we see on the imaging findings. I will talk about this imaging finding in detail, then I will show you some cases. I want you to, in the chat box, you can write your diagnosis, case number and the diagnosis, just so that we can discuss. The first is the size. The most of the ring enhancing lesion in neurocystic sarcosis or candida abscess, when they are single, they are less than 20 millimeter in size. Like this example of NCs in the thalamus, we see ring enhancement less than 20 millimeter. Then tuberculoma, single tuberculoma or abscess or lymphoma, they are mostly larger than 20 millimeter in size. Like this is example of tuberculoma with isodense core with ring enhancement. This one, middle one, is the example of abscess. Can you see my cursor? Okay. Then we'll look at the...
Yes, sir, it's visible.
Yeah, core of the lesion. The core of the lesion is hypodense in cases of neurocystic sarcosis abscess, while in cases of tuberculoma, fungal abscess, thrombosed aneurysm, the core is hyperdense. This is one of the very important differentiating features on CT scan. Then how is the core appearance on T2 weighted images? When the core contains lipid content, it will be bright on T2 weighted images, like in case of the neurocystic sarcosis. This example abscess, this is NCC, where the core is bright on T2 weighted images. On the other hand, in tuberculoma or fungal abscess, the core is hypointense on T2 weighted images. This example of tuberculoma with multi-layered appearance, the core is hypointense. This is example of fungal lesion, or this is the example of multiple small tuberculomas with core is hypointense. So sometimes the NCC in the late stage can have hypointense core. Then how is the ring enhancement, the wall of the ring enhancing lesion? In the case of the abscess NCC, the wall is smooth without any nodularity. On the other hand, in the mass lesions or fungal abscesses, this wall is nodular and lobulated outline. Like this example of fungal abscess, where the medial margin of the wall is lobulated in appearance. Then whether the ring is complete or incomplete. In case of the abscess and most of the lesions, the complete ring enhancement is seen. However, the incomplete ring enhancement is mainly seen in demyelinating lesions. So this is example of multiple sclerosis where the incomplete ring enhancement is seen. Then how is it imaging single or diffusion weighted images? First thing to remember, never interpret diffusion weighted images without any ADC. So this is a diffusion weighted images with ADC map. This is showing complete diffusion restriction within the core. It is bright on diffusion weighted images and dark on ADC map. The complete diffusion restriction in the core of the lesion mainly seen in bacterial abscess, or sometimes it can also seen in tubercular abscess. On the other hand, the fungal abscess, the diffusion restriction is peripheral in most of the time. The wall will show restriction, or then there's a peripheral restriction because of the there's a projection from the wall. On the other hand, the demyelinating lesions, the peripheral ring of the lesion the peripheral advancing margin will show diffusion restriction. This will appear bright on diffusion weighted images. So we should look at whether diffusion restriction is present or absent, or when it is present, what is the appearance of this diffusion restriction, whether it is the core or it is in the wall, whether it is central, eccentric. Then the perfusion is helpful in differentiating neoplastic etiology from non-neoplastic etiology. In cases of, like this example of glioblastoma, where perfusion will be increased in the wall of the lesion, or lymphoma metastasis. On the other hand, demyelinating lesions, the perfusion will not be increased. Example of tumefactor demyelination, where there is incomplete ring enhancement, or there is no increased perfusion on perfusion weighted images. These are the perfusion diffusion are the problem solving tool. When you are not able to differentiate on conventional imaging, we do these kind of imaging. Then spectroscopy, in case of the abscess, spectroscopy helpful in differentiating the causative agent. Like in pyogenic abscess, you will see acetate peak larger than the succinate, and you get lipid, lactate, and amino acids. On the other hand, in the neurocystic sarcosis or other parasitic cysts like hydrated cyst, you will see large succinate peak larger than the acetate. On the other hand, in tubercular abscess, you will see lipid, lactate, and in tumors, you will see choline and the lipid. But one must remember that we should not interpret spectroscopy alone. Always look at your conventional imaging and use spectroscopy as a problem solving. You can't make any diagnosis based on spectroscopy alone. Let's look at the cases. This is a case 1, 12-year-old boy with left focal seizures for last 4 days. We have got plain scan and the contrast. What we see, a ring enhancing lesion. The core is hypodense. There is eccentric hyperdensity, that is because of the scolex. There's an edema around this lesion. There's a thick ring enhancement. Remember one thing, the degree of edema is not a differentiating feature. In most cases of the neurocystic sarcosis, the edema is less. Sometimes you get a gross edema with midline shift. So it should not be used as a differentiating feature between neurocystic sarcosis or tuberculoma. So this is a case of NCC where you see the scolex, hypodense core. Scolex, this is the conventional appearance of NCC on MR. It will appear hypointense on T1 weighted images, bright on T2 weighted images. The bright signal on T2 weighted images will suppress on the flare sequence. There is edema around this lesion. The scolex is best seen on this cyst sequence, where it is shown as an eccentric hypointensity. It may show diffusion restriction, and on contrast, it shows peripheral enhancement. This is the classical imaging appearance of NCC on MRI. The appearance of NCC on MR depends on the stage of the lesion. The first stage is a vesicular stage where cyst is live. What we'll see a cyst up to 20 millimeter in size, where the signal intensity of the core of the lesion will be isointensity or CSF. There will be minimal to no edema around the lesion, and most of the time these cysts shows no enhancement. When this cysts start degenerating, the fluid will become turbid, so it will appear hyperintense on both T1 and T2 weighted images. It will show ring type of enhancement and perilesional edema. In the granular nodular stage, the edema will increase, the thickness of the ring will be increased. There may be polycystic leakage of contrast in the adjacent white matter. And in the final stage, what we see a calcified disc lesion with or without any edema. In the later stage, the edema disappears. So this is a continuum of these stages of NCC on imaging. So how to make the diagnosis of NCC? First, you have to look for the scolex. The scolex is seen as eccentric hyperintensity. And then this is another case of example, you see the eccentric hyperintensity of the scolex. The thickness of the ring and degree of edema is not a feature. Like here, there's a midline shift, there's a lot of edema around this lesion. Second, the scolex is best seen on the thin slices CT. Now in the multi-slice CT, we acquire slices in 2 millimeter thickness. Like in this case, you see a ring lesion with perilesional edema on 6 millimeter slice, but on 2 millimeter slice, you can see the scolex well. So we conducted a study and found that the sensitivity of scolex detection increased from 54% to 93% when you use thin slices CT. So in this era of multi-slice CT, we can reconstruct in 1 millimeter or 2 millimeter. We should always do this kind of reconstruction and look for this scolex. Second, scolex is seen as a isointensity on T1 weighted images, hypointensity on T2. and you will see, it will show ring type of enhancement. Sometimes it's difficult to see, like in this example, the cyst is in the region of the thalamus, but if you zoom this image, you can clearly see the eccentric scolex. So wherever possible, try to see soft copy of the images rather than the hard copy. In the soft copy, you can zoom the images, you can look images more clearly. Like in this case, you see this is not a single cyst, there are multiple 3 cysts are there, and one of the cysts is showing eccentric scolex. So this is example of thalamic NCC. Around 30 to 40% of the NCC, you don't see any scolex. This is a case of resolving NCC. You see just a ring enhancing lesion with edema. If you follow these cases, this edema will disappear. This ring will resolve itself. Another example of ring enhancing lesion without any scolex, and this is also resolved. So even if you don't see a scolex, but patient present with a single seizure without any constitutional symptoms, don't jump to make the diagnosis of tuberculoma. It is well be a NCC. We should follow such patients without any ATT, and most of these lesions regress. Then another feature is the core signal intensity on flare sequences. Like in this case on T2 weighted images, the core of this lesion is bright on T2 weighted images, and it is getting suppressed. It is like CSF on T1 weighted images. So this is the flare suppression. The lesion is bright on T2, dark on flare. This can never happen in tuberculoma, because in tuberculoma, the core is never like CSF. So this is the suggestive of NCC. This is seen up to 25% cases of the NCC. It's one of the differentiating feature between NCC and tuberculoma. Then degree of perineal edema is quite variable. Like in these 3 examples, in frontal lobe, midbrain, thalamus, there's a lot of edema is there, and this lesion regressed without any ATT. Then on the diffusion weighted images, NCC can show diffusion restriction up to 25%. This diffusion restriction can be complete, like in this patient in the pontine NCC, you see the complete signal restriction in the core of the lesion. It is appearing bright on the diffusion weighted images or dark on ADC map. So it's a conglomerate NCC, and one of the cysts is showing diffusion restriction. On the other hand, sometimes the diffusion restriction can be eccentric. Like in this example, there is eccentric focus of diffusion restriction, which is bright on diffusion weighted images and dark on ADC map. So we should not make a diagnosis of tubercular microabscess. I've seen like people making diagnosis of tubercular microabscess whenever they see diffusion restriction. So diffusion restriction can be very well seen in NCC. This is another example of the midbrain NCC. We see focus eccentric diffusion restriction at 2 points. So like on this slice, it is medially, and in the upper slice, this is posteriorly. These are dark on ADC map. So this is a conglomerate NCC in the region of the midbrain on the right side with focus of diffusion restriction. So remember that diffusion restriction can be seen in NCC. Let's look at the second case. This is a 13-year female with headache and seizure on one day, but we got a T1, T2 flare sequences. Or to see conglomerate ring enhancing lesion. Whenever you see a conglomerate ring enhancing lesion, you look for 3-4 things. First, look for if any of the cyst is showing diffusion restriction. Second, if any of the cyst is showing loss of flare suppression. Third, if you see any leakage of contrast around the surrounding white matter. Like in this patient, there is a focal area of diffusion restriction. One of the cysts is showing. There is a leakage of contrast in the surrounding white matter. The upper slice, we clearly see there's a leakage of contrast outside the boundary of the cyst into the white matter. Here also it's very well seen. Another example, similar conglomerate ring enhancing lesions with leakage of contrast in the surrounding white matter, and there's a focal area of diffusion restriction. And the first case, the repeat scan after 10 weeks without any ATT, all this lesion resolved. And second case, after only 17 days, there's a significant regression of these lesions. So these are the example of Neurosciences sarcosis, which are presenting as a conglomerate ring enhancing lesions. So what we have seen this perilesional leakage of contrast. We have seen in up to 25%, 24% cases of the NCC. None of this around now we have got 50 cases of tuberculoma. We have not seen this finding in cases of tuberculoma. This may be a valid differentiating feature between neurocystic sarcosis from neurotuberculoma. Let's look at the third case. What we see is multiple conglomerate ring lesion in the thalamus. So I told you three things to look for. Look for any flare suppression. Like this, on this side, the core of the lesion is bright on T2 weighted images and it is dark on flare sequence. It's very well. If you zoom the image, you can see the flare suppression. You can see the scolex on the SWIC, on the cyst sequence. So this is an example of multiple thalamic NCC appearing as a conglomerate. These are the follow-up scans in the same patient without any ATT. These lesions regressed over a period of time spontaneously. Another example of conglomerate ring enhancing lesion with leakage of contrast and the adjacent white matter, conglomerate appearance. Most of the time, these are mistaken for tuberculoma. This is a follow-up scan. All this lesion regressed. So we published in 2018 the conglomerate ring enhancing lesions are more common in solitary NCC and they don't suggest tuberculoma. In our experience, the conglomerate NCC are more common than the single discrete NCC. Then when we see multiple ring enhancing lesions, there are two main differential, whether it is a tuberculoma or NCC. In NCC, you will see lesions in different stage of evolution. You will see a calcified lesion, you will see a lesion with scolex, you will see enhancing lesion, non-enhancing lesion. That will not happen in tuberculoma. So this is an example of multiple conglomerate, multiple NCC with hydrocephalus. Another example, now on the MR, you can see one of the cysts in the thalamus. It is showing flare suppression. It is showing enhancement. A few cysts are not enhancing. A few are showing edema. A few are not showing edema. So what we see the lesion, and one of the lesion is showing diffusion restriction. So what we see the lesion in different stage of evolution. So this will suggest the diagnosis of NCC rather than neurotuberculoma. Then sometimes when the multiple cystic sarcosis are present in the granular stage, there's an overwhelming inflammatory response and there's a lot of edema around this lesion. This is known as cystic circle encephalitis, where the patient is present with altered sensorium with multiple seizures. Then in our experience, recurrent NCC is seen up to 15% of the cases. Like in this example, we'll see a cystic NCC with scolex on the right frontal. This lesion is resolved during follow-up and new lesion is seen in the other location. In this case, this is a lesion, we'll see a frontal lesion with eccentric scolex. Scan repeated after 3 years, you see a lesion almost in the same location with eccentric scolex. Look at the position of the scolex. The scolex is different. We fuse these images. They are one new recurrent lesion in the same location. What we have seen is recurrent NCC is much more common in the same location rather than in a different location. Most of the time, these are mistaken as persistent lesion rather than recurrent lesion. Like this is the example. This patient has got 4 scans. Between first and second scan, there's a lesion, the edema resolved, the lesion size regressed. Then after 3 years, on the same location, the lesion edema also, the size increased, the edema increased, which regressed. And there was no ATT given all this during this follow. This is the adult patient. What we'll see here, thalamic, this pontine lesion with eccentric scolex. But during follow-up, this lesion was single to begin with. Now they become twice. There are 2 lesions. One is disc, one is ring enhancing lesion. Enlarging NCC also very well seen. They should not be mistaken for tuberculoma. Like these are the multiple example of this single ring enhancing to begin with. This is the new lesion adjacent to the old lesion. And this is a single ring in the left frontal becoming 2 conglomerate ring enhancing lesion and regressing spontaneously during follow-up. So recurrent NCC and enlarging NCC should not be mistaken for tuberculoma. If you do spectroscopy in NCC, you will see a large succinate peak. When the cyst is very large, you can put the voxel well inside this core of the lesion. You will see succinate peak, which is larger than the acetate peak. It's well known. Like this case, but to see a midbrain NCC with a classical scolex. Our resident was very enthusiastic. We did MR, and during MR, he did the spectroscopy. But we'll see the lipid peak in NCC. Then we reviewed the literature. There are case reports of lipid peak in NCC. So lipid can be seen in NCC. Presence of lipid alone should not be diagnostic of neurotuberculoma. And then during follow-up, this lesion regressed. There is another example. We see same midbrain lesion with scolex, eccentric diffusion restriction, multiple congruent lesion. This patient has got MRI done from outside with spectroscopy. A spectroscopy is showing lipid lactate in the same location. So we have seen around 4 or 5 cases where the lipid is seen within the NCC. And there is no contamination from the scalp lipid. Their lesion is located well in the center. The spectroscopy quality is good. So lipid can be seen. So one should not interpret the spectroscopy alone in differentiating NCC from neurotuberculoma. These are the follow-up scans in the same patient. This lesion regressed during follow-up. Then up to 25% of the NCC can be within the ventricles, there where the fourth ventricle is the most common site, followed by the third ventricle. This may be missed if you do the conventional T1 and T2 weighted images, but they are very well seen on the cyst sequence, where you see the cyst and you can even see the scolex inside the cyst. Then cysternal NCC can be seen up to 3 to 5%, where you see grape-like cluster of cyst without any wall, mainly seen in the region of the Silmian fissure and basal cistern. Sometimes you see just the enlargement of the sulci rather than any well-defined cyst. This cysternal cysticercosis can lead to vasculitis in up to 50% of the cases, where they may present as a stroke also, with occlusion of the MC or PC, posterior cerebral artery, occlusion causing infarcts. So this is one of the complications of cysternal NCC presenting as infarcts. So neurocysticercosis mainly seen in the parenchyma, extraparenchymal is seen in subarachnoid, intraventricular, and most of the time, up to 25%, you get mixed parenchyma plus extraparenchymal. So while interpreting NCC, you should look at your flare sequence, look for the flare suppression, do thin T2 cysts or fiesta sequence to look for the scolex. Flare suppression rules out tuberculoma. We can say diffusion restriction, which can be complete in the core or could be eccentric, and conglomeration is a common presentation in NCC. This is another patient, this is an adult patient. This patient presented with seizures in emergency. What we see a lesion, isointense lesion with focal calcification with midline shift. This patient lost to follow-up. We did repeat scan after 3 months. What we see a conglomerate ring enhancing lesion with diffusion restriction, and there is a focal area of calcification within this lesion. I just want to give you the message that whenever you see any lesion, try to see the previous image. This patient has got the previous MR, previous CT scan done 3 years back. There was a small NCC in the same location with eccentric scolex. So this was turned out to be NCC, where the single lesion has grown into the large conglomerate mass-like appearance. And we followed up this lesion, and this lesion regressed. This was stable for a year, then start regressing itself. The fifth case is a 13-year-old girl presenting with seizures. What we see a lesion which is isodense core, multiple conglomerate, size is more than 20 millimeter. Size of the largest lesion is more than 20 millimeter. It shows a thin, smooth ring enhancement. So this is the imaging of appearance of neurotuberculoma. Isodense core is suggestive of diagnosis, and size is more than 20 millimeter. The most of the tuberculoma, they show solid larger than 20 millimeter, iso to hyperdense core. And if you do empty sequence, it will show the lower empty. In the empty own sequence, it will show peripheral rim of hyperintensity. And if you do spectroscopy, it can show increased lipid. If you include the wall of the tuberculoma, it will show increased choline. So one must be careful where you place the voxel. Tuberculomas, they can mostly occur in the corticomedullary junction. They can be non-caseating tuberculoma, or they will be caseating with solid center or caseating with lipid center. Let's look at the imaging appearance of various tuberculomas. The non-caseating tuberculoma will show homogeneous enhancement, and they will be bright on T2 weighted images. On the other hand, the caseating tuberculoma, they show ring type of enhancement, where the core is hypointense on caseating granuloma with solid center, and bright where caseating granuloma with liquid center. What we see here, the ring enhancing lesion, the core is multi-layered appearance, hypointense on T2 weighted images, bright on T1 weighted images. This is the caseating tuberculoma, where the core is dark and shows ring type of enhancement. The caseating tuberculoma with solid center. Another example of caseating tuberculoma with solid center in the cerebellum. It has irregular outline, hypointense core, peripheral enhancement, and it is bright on T1 weighted images. Similarly, this is another example of thalamic tuberculoma, where the rim is becoming brighter on empty sequence. This is empty off, this is empty on, the rim become brighter. On perfusion, the perfusion is not increased, and our spectroscopy shows a large lipid peak. All these features that suggest diagnosis of tuberculoma: irregular outline, peripheral enhancement, T2 dark core, bright rim on empty on sequence, large lipid. On the other hand, the tuberculoma with liquefied necrosis, the core will be bright on T2 weighted images, and it will show peripheral enhancement. Let's look at this 12-year-old girl with fever for 15 days, headache, vomiting. What we see: multiple ring enhancing lesions. The core is bright on T2 weighted images, but look at the basal system. There is a leptomeningeal enhancement in the basal system. So we will see multiple ring enhancing lesions. Size is less than 20 millimeter. A core is hyperintense. This is a case of multiple tuberculoma in the setting of tubercular meningitis. In this case, you'll see multiple ring enhancing lesions. If you look carefully, the core of the lesion is hyperintense on T2 weighted images. None of this cyst is getting suppressed on flare. They are dark on T2 weighted images, that's why they are dark on flare sequence. So there is no flare suppression, ring type of enhancement, all the lesions of the same stage. So this is example of multiple tuberculoma. On the other hand, in NCC, you will see lesions in different stage of evolution. This is an example of gyriform tuberculosis, where the lesion is isointense on T2 weighted images, dark on T1 weighted, dark on T2 weighted images, shows peripheral gyriform enhancement. Perfusion is not increased. There is a large lipid peak on spectroscopy. There is no hemorrhage. It should not be mistaken for mass lesion or mitotic pathology. Perfusion is not increased. The pattern of involvement, the gyriform pattern, and T1 hyperintensity will suggest a diagnosis. Let's look at the sixth case. Is that 11-year-old boy presenting with fever and altered sensorium. What we see: a lesion which is showing peripheral smooth ring enhancement. The core of the lesion is showing diffusion restriction. And on spectroscopy, you got lipid lactate, acetate peaks, and acetate peak larger than the succinate peak, plus there is a multiple branch change amino acid. So this is a suggestive of pyogenic brain abscess, where you see diffusion restriction within the core of the lesion, smooth ring enhancement, and branch change amino acids. Another example of pyogenic brain abscess. Look at your diffusion weighted images. This is the core of the lesion is showing diffusion restriction. The two conglomerate ring lesion. It is dark on ADC map. The wall is smooth. There is no nodularity. Other differential diagnosis in such cases is the GBM. In GBM, the wall will be nodular. And if you look at your perfusion, the perfusion will be increased in GBM. Here, the perfusion is not increased. And in tubercular brain abscess, you will get large lipid peak. Another example of tuberculoma with ring enhancement. Here, if you include the wall of the tuberculoma, you will get large choline peak in addition to lipid lactate. This imaging, this spectroscopy is like GBM. If you see spectroscopy alone, the GBM will also show a large choline peak plus lipid lactate. So one must look at the position of the voxel whenever you are interpreting a spectroscopy. This is an example of brain abscess, shows complete diffusion restriction, peripheral rim, and this is a large lipid peak. Then in pyogenic brain abscess, this is a case of congenital heart disease. Patient is presented with altered sensorium fever, the diffuse leptomeningeal enhancement. What will say ring enhancing lesion, which is showing diffusion restriction. On SWI sequence, you will see inner ring of hyperintensity and outer ring of hypointensity. This is known as dual rim sign. That is mainly seen in pyogenic brain abscess. The inner rim is because of the granulation tissue, and outer is because of the macrophages with the hemorrhages That suggests the diagnosis of pyogenic brain abscess. Another patient is a 14-year-old boy with HIV positive present with ring enhancing lesion. What we see a ring enhancing lesion. Here, look at the pattern of diffusion restriction. Diffusion restriction is seen in the periphery of the lesion. This area which is showing diffusion restriction is not showing any enhancement. Enhancement is outer to this area of diffusion restriction. So this is classical of fungal abscess, where this intracavitary projection shows diffusion restriction, or this intracavitary projection don't show any enhancement. A spectroscopy can also mimic show lipid lactate like in other brain abscesses, but this diffusion restriction is helpful in making the diagnosis of fungal brain abscess. So intracavitary projection is helpful in making the diagnosis. So fungal brain abscess, the ring enhancement sometimes may be subtle depending on the immune status. So how to differentiate bacterial from the fungal brain abscess? Bacterial abscess is mostly single, has got a smooth wall, no intracavitary projection. Diffusion restriction will be seen in the core of the lesion. And on spectroscopy, you'll get amino acid liquid lactate. On the other hand, the fungal abscess is multiple crenated border, intracavitary projection, and diffusion restriction will be seen in the wall and projections. Sometimes in patient with congenital heart disease, you get multiple brain abscesses. This is an example of multiple brain abscess, multiple ring enhancing lesions with smooth wall, suggestive of abscess. This is an adult patient I've taken. This is 32 years male presenting with HIV. What we see, multiple conglomerate ring enhancing lesion in the region of the basal ganglia, which are not showing increased perfusion. These lesions are showing central hyperintensity on T2 weighted images with hypointense rim. And the location of this lesion is classical. This is mainly seen in cases of toxoplasmosis, where you get necrotizing encephalitis with peripheral rim of hyperintensity. You get areas of hemorrhage which are bright on T1 weighted images, ring type of enhancement. And sometimes you get the eccentric nodule in up to 30% of the cases. Basal ganglia is most common location, but most of the time, in 85% of the cases, these lesions are multiple. And if you do spectroscopy, it will show a large lipid lactate peak, like in tubercular brain abscess, but the core will be bright in such cases. And they will get areas of hemorrhage on T1 weighted images, which will be appearing bright. So this toxo patient in a patient should be differentiated from lymphoma. Lymphoma will show diffusion restriction, which is not a feature of toxoplasmosis. And the perfusion will be low in cases of the toxoplasmosis, while it will be higher in cases of lymphoma. Let's look at the 16-year-old boy with Hodgkin's lymphoma presenting with seizures. But we see multiple small ring enhancing lesions. We thought it could be small tuberculoma or maybe small NCC. We did MR. MR shows the multiple small micro abscesses. All the lesions are showing diffusion restriction with lot of edema all this lesion. This micro abscesses has been described in cases of candida brain abscess. In candida, all the lesion will show abscess formation. The biopsy was taken, it turned out to be candidal abscesses. So there are four main groups. First is micro abscesses, which are less than 3 millimeter in size, but we'll see punctate nodular enhancing lesion. Then we can see meningitis. Rarely we can see macro abscesses or complication in the form of vasculitis or mycotic aneurysm in cases of the candidiasis. Another lesion which can present with ring enhancing lesion is the hydrated cyst. Most of the hydrated cysts don't show any enhancement, but one type of hydrated where there are different 5 appearance of the hydrated. One of the hydrated where the multiple conglomerate ring enhancing lesions may show peripheral area of hyperintensity. Most of the time, the imaging appearance is uniocular cyst without any enhancement. But rarely, hydrated cyst can also show enhancement. But if you do spectroscopy, you will get large succinate peak, which is helpful in making the diagnosis. Let's look at the last case. This is a 12-year-old boy presented with focal seizures. What we see is there's a lesion in the left frontal. The core is bright on T2 weighted images, and there's a peripheral edema around this lesion. This is called lesion within lesion appearance, or we call it fried egg appearance. That suggests demyelinating pathology. On contrast analysis, there's a peripheral rim of hyperintensity. This rim is incomplete, smooth, On spectroscopy, there's an increased choline, there's a lipid lactate is seen. Perfusion is not increased, and this is the follow-up scan. So this example of two-factor demyelination, where it is showing incomplete ring enhancement, no increased perfusion. This is another example. This is also example of two-factor demyelination, where lesion within lesion appearance is seen. Here the enhancement is complete. So sometime in two-factor demyelination also, the ring enhancement can be complete. But look at the diffusion weighted images. The peripheral rim of enhancement is showing diffusion restriction. And this is the follow-up after 3 weeks, the lesion regressed in size. So most of the two-factor demyelination, they are large, more than 2 millimeter, 2 centimeter demyelinating lesions. They have the T2 hypointense rim. The mass effect is minimal. The edema is variable. It can show the open or incomplete ring of enhancement. These are the list of the disorder which can show large two-factor demyelinating lesions. This is the case. This 14-year boy presented with multiple cranial nerve palsy. But we see a large ring enhancing lesion in the pontine lesion. Could this be tuberculoma? The core is not bright on T2 weighted images. We did perfusion. There is a increased perfusion in the wall of the lesion. So this turned out to be GBM. So we should always look at perfusion weighted images when you want to differentiate whether it is an infection or some other pathology. This is the last case. What we'll see, a hyperdense core with peripheral area of calcification. The lesion is located in the vermis and on the DSA, it shows a large venous pouch. So this is thrombosed venous pouch in a case of AVN. So to conclude that imaging abnormalities is key to successful diagnosis of ring enhancing lesion. We should always look at the clinical presentation, whether patient is immunocompromised or immunocompetent. In cases of the small, less than 20 millimeter ring enhancing lesion, look for the scolex. In NCC, you can see the conglomerate ring enhancing lesions. Look for your flare signal intensity, whether the signal is getting suppressed in flare sequences. In the post-contrast image, look for any leakage of contrast. In the perfusion weighted images, look for the increased perfusion in the wall of the lesion, which will suggest a mitotic pathology. And in spectroscopy, you can see succinate amino acids. Even lipid can be seen in cases of NCC. If there is no clue, we should do appropriate CSF and other investigation. And still no clue, we should do biopsy. Thank you.